we're going to see is Corey's, and the presentation is Use of Virtual Worlds in the Treatment of PTSD.
Hello everyone, I hope you all can hear me. Excellent. Well, my name is JenChristensen, and tonight we will be exploring virtual reality exposure therapy in the treatment of post-traumatic stress disorder, or PTSD. And I first want to apologize, some of my slides are a little dark, so you may not be able to see the content, so you'll just have to pay closer attention to what I'm saying, so I apologize in advance. All right, give me just a second here. All right. PTSD did not officially enter our vocabulary until 1980, when it was formally added to the Diagnostic and Statistical Manual of Mental Disorders. It is now defined as an anxiety disorder that may develop after exposure to a terrifying event or ordeal in which severe physical harm occurred or was threatened. Traumatic events that may trigger PTSD include violent personal assaults, natural or unnatural disasters, accidents, or military combat. PTSD symptoms usually manifest shortly after the traumatic event. However, they may not appear until months, even years later. And to further complicate matters, some of these symptoms may come and go over a span of several years. PTSD symptoms are typically grouped into 4 categories. Intrusive memories, which include recurrent and unwanted flashbacks that cause severe emotional or physical distress. Avoidance, in which an individual tries to avoid situations or other individuals that trigger memories of the traumatic event. Negative changes in thinking and mood, where the individual is unable to experience positive emotions, maintain close relationships, or is not interested in activities that were previously enjoyable. There are also intense feelings of fear, guilt, or shame. And finally, changes in emotional reactions, most commonly referred to as arousal symptoms. And these are characterized by irritability, aggressive and self-destructive behavior, and insomnia. While military engagement has historically varied in terms of intensity and duration, recent studies on veterans returning home from Operation Enduring Freedom and Operation Iraqi Freedom are particularly troubling. The sustained and intense combat operations of both wars, not unlike the Vietnam War, have generated serious long-term mental health concerns. There are generally 2 approaches in treating PTSD, either antidepressants or SSRIs, typically Prozac, Zoloft, or Paxil, or psychotherapy, which includes, for the purposes of this particular presentation, prolonged exposure therapy. Of the psychotherapy treatment options available, prolonged exposure, or PE therapy, has produced significant scientific evidence supporting its therapeutic efficacy. This treatment involves an actively repeating imaginal narrative and reliving of the patient's trauma. It's considered a low-threat approach, and it provides the patient an opportunity to confront and process trauma-relevant memories, while also deconditioning the patient, which is also referred to as habituation or extinction. Despite its efficacy, however, many veterans are either unwilling or unable to effectively imagine the traumatic event, thereby avoiding the trauma, which, as we now know, is a cardinal symptom of PTSD. In order to combat this, researchers, with the support of the Department of Defense, have started exploring virtual reality as a tool for delivering exposure therapy. Virtual reality exposure therapy, also known as VRET, is an effective tool in circumventing a patient's natural avoidance tendencies by way of immersing the patient in virtual simulations of their personal trauma. Additionally, VRET provides the clinician the ability to control with precision the simulation's emotional intensity, while also tailoring the relevance and pace of the patient's exposure. VRET is especially effective in eliminating barriers to therapeutic care, since many veterans returning from Iraq and Afghanistan now considered to be part of the new digital generation, are more willing to participate in such progressive treatments rather than more traditional talk therapy options. Recognizing that behavioral therapies would have to adjust in order to provide effective and quality care to a new generation of veterans, the USC Institute for Creative Technologies, funded by the U.S. Office of Naval Research, developed the virtual Iraq-Afghanistan VRET system between the years 2005 and 2007. The simulation consists of several virtual scenarios, usually desert or city scenes, which is also enhanced by additional olfactory, audio, or vibrotactile stimuli. These stimuli are ultimately controlled by a therapist with an independent interface called the Wizard of Oz, which allows for a customized therapy session for the veteran, addressing their specific therapeutic needs. To date, the virtual Iraq-Afghanistan systems have been deployed to approximately 60 clinical sites, including VA centers and several university, private, and military medical centers. The VRET treatment program adheres to a standard evidence-based protocol and is comprised of weekly 90 or 120-minute personalized sessions over a total 10-week period. The first session is more or less a patient and clinician meet and greet, and is designed to establish the baseline therapeutic relationship. The veteran's traumatic experiences may also be generally discussed at this time. The second session, which builds upon the first, the clinician communicates to the patient the explanation and rationale for PE therapy. The clinician may cautiously introduce imaginal exposure exercises, which introduces the patients to the process while also addressing less provocative aspects of their trauma. The third session builds on the explanation and rationale of PE therapy by introducing the more specific rationale for VRET and allowing the patient to explore for an initial 25-minute period the virtual Iraq-Afghanistan simulation. And it's a simulation that will be most applicable to their own personal combat experiences. This session is primarily designed to help the patient familiarize themselves with the technology, thereby bridging the gap between imaginal exposure and VRETs. The 4th through 10th sessions are complete VRET therapy sessions in which the patient is alone navigating the technology while also verbally recounting their specific trauma. The clinician designs the simulations in order to have the patient experience moderate yet manageable anxiety levels in order to compel the patient to confront the more provocative elements contained within the VRET environment. The USC Institute for Creative Technologies has recently started expanding the scope of the virtual Iraq-Afghanistan simulations in their development of the Stress Resilience in Virtual Environments, or STRIVE programs. This project is designed to encourage stress resilience by developing a series of combat simulations used to aid soldiers in acquiring stress reduction exercises and cognitive behavioral emotional coping mechanisms prior to their deployment. These soldiers are immersed in a variety of different virtual mission-like scenarios where they must confront and process emotionally challenging situations that would be common in most combat situations. This is accomplished with the design of a 30-episode narrative training experience that spans an average deployment cycle. Each 10-minute episode concludes with an emotionally distressing event in which a virtual human mentor character enters to guide the user through the simulation, encouraging them to employ appropriate coping mechanisms. The U.S. Department of Defense has since adopted the STRIVE program as a standard classroom-delivered training program. Early clinical trials have produced encouraging results. One trial in particular, involving 20 active duty service members who participated in an average of 11 VRET sessions, resulted in 16 of the 20 participants no longer meeting the criteria for PTSD after treatment, with an average 50% decrease of PTSD symptoms amongst all participants. As encouraging as these results are, however, VRET technology is still in its early stages and is wholly dependent upon continued positive efficacy results and cost-benefit analysis. However, support by the Department of Defense and the Department of Veterans Affairs is encouraging and reflects the sense of urgency to address the psychological wounds of war. After all, history has demonstrated that innovations in military healthcare positively influences civilian healthcare. Ultimately, technology is merely a tool. BRET technology does not completely cure PTSD. It merely aids in training or extending the skills of already well-trained clinical professionals. We can, in the meantime, remain hopeful that these new innovative and immersive technologies will realize their potential and have a lasting impact on both military and civilian healthcare. Thank you, everyone. This has been a wonderful experience.